that this is what someone thinks ought to happen. Whether the doctor, the nurse, the respiratory therapist, somebody has come in and go, I think you ought to, and they haven't given all the options. You, as a volunteer chaplain, could encourage the patient to ask more questions. You could encourage the family to ask more questions. You can encourage the nurse to come back in and say, are those all the options? The doctor to come in, is there anything else we can do to assist them in getting plans of care, not just one push, but maybe, okay, now that you mention it, we could do this, this, or this. Then allowing the patient to make a decision to go through that with all the options. That is informed consent. Physician agreement with this. If you were hiring me as your doctor, and I was making an agreement with you, once upon a time you come in my doctor's office and you say, hey Larry, you as my doctor, if I ever get sick, let's just make an agreement, you make me better every time. That's kind of the doctor agreement. It's never the agreement just, oh, don't worry about that. You're always saying, fix it, fix it, fix it, fix it. There's some kind of simple agreement that we have with our doctors that say, when I'm sick, make it better. Well, when does the doctor know when you believe enough is enough? Because they're going to keep looking into that medical bag going, I've got another trick. I've got another, okay? Now, part of that is the agreement. When I get sick, you make me better. Part of that is the legal. I'm going to err on the side of doing more rather than on the side of doing less. Now, you've all been watching the nightly news, and you look on your TV program and you see a certain attorney going on the screen there going, you know, if you've seen mom left in a nursing home too long, or your doctor did miss something. I never see any attorney ads going, if your doctor did too much, if they were doing too much medical care, give us a call. Okay? So they're running scared, trying to do too much rather than too little. Okay? So what do you guess is going to happen in the medical care of somebody who's 80 and 85 and 90, or somebody who's very sickly? They're going to keep thinking, what did I miss? What did I miss? There's something else I need to do. Okay? That's just the picture. Okay? With all that litigation hanging over them, with this high five agreement, doctor, when I get sick, you make me better. The goal is going to be, I got to do more, I got to do more. And those doctors tell me that when a patient dies, they're always thinking about, what did I miss? What did I miss? It must have been something. I don't know. They're not just saying, okay, they were 95. It's, I missed something. Because I have a patient over here who's 97, and they're doing fine. Okay? So it's like always in the goal to fix it, fix it. So here is the goal here in the medical care. When do you as a patient, when does your mom and your dad as a patient say, that's enough. Thanks, doc, for doing all you can. Throughout my life, you've taken great care of me. You've gotten me out of this situation, you've done wonders. But as of now, I'm saying no more. That's a tough decision. You know, for each one of us, when do we say enough's enough? It may be easy for you, the person that's not sick in the bed, to go, I would. But there's the person laying in the bed going, well, I don't know, this is tough. But for other people, they make the decision like that. That's it, no more discussion, that's what I want to do. I want surgery or don't. I want this treatment or don't. Different people and different personalities handle it a different way. I remember one day when there was a minister in our hospital, and a nurse just scolded him up and down because he was so scared. He was just about the point of death, and she goes, you're preaching all this all the time. It's like, well, people handle dying, not death. I'm understanding the eternity thing, but I don't like this being sick thing. I don't like this being in pain thing. I don't like this going through suffering thing. Not any of us do. Okay? So there is that part in that illness. What's going to happen with me? You as a minister may be very useful in that moment of gathering information, because sometimes we don't answer that question well enough for those. We're not saying, well, okay, we're going to take care of the pain. We have hospice care. We have these kind of treatments we can do for you. So we're not giving that. We're kind of like, well, they know about hospice care. Maybe they don't. Well, they know we're always going to keep them out of pain. No, maybe they don't. So sometimes they're asking some simple questions. Am I going to hurt? Am I going to suffer? I know there's some hurt, some suffering in death, but are you going to do your best to take care of them? Some of our part is to help them get to that ability. So patient and families may be talking about viable life and quality of life. Doctors don't really use those kind of terms much. They understand it as a human being, but in their medical profession, they're not talking about that. Physicians are more concerned about the diagnosis. What is the illness? The prognosis, is it poor, guarded, or grim? And is there a reasonable recovery? In the living will, as we talked before, that all patients will be resuscitated. They will be evaluated for reasonable recovery, and then remove life support only if the prognosis is poor. So they will give everyone a chance. Any questions so far? Stop me, halt me, slow me down, because I'm just going to be like a freight train trying to get all this information in today, but slow me down if you have a question or comment. Three main choices in our medical care. Aggressive measures, meaning they're trying to lick the problem, they're trying to cure the disease, and that patient is called a full code, meaning they will do life support, do all that's necessary to sustain life. Or aggressive measures and a D.N.R, meaning this patient has a do not resuscitate order. They're not going to do chest compressions or the paddles or any of that, but we are going to go to surgery. Or we are going to do this treatment. We might be on dialysis. We might go and try to do a heart catheterization or open heart surgery or any kind of treatment, because the patient's going, that's what I want, but I don't want CPR. If my heart stops, let me go. So you can have the choice of both. Or palliative measures, meaning to take care of the pain, have a do not resuscitate order, and be on hospice care. That kind of simplifies it a little easier. I know there's a lot of choices in between, but if we kind of think of that as aggressive care and full code, or I want treatment, but don't resuscitate my heart, or it's time to let go, no CPR, I have a D.N.R, be on hospice care, take care of my pain management, those things. It kind of simplifies it a little easier. Aggressive measures and full code, meaning that do everything that is medically necessary to cure the disease, and full code, meaning that you try chest compressions, crash cart, ventilator, paddles, or anything like that. The aggressive measure and D.N.R, meaning do not perform chest compressions and all that. It does not mean do not treat. Some patients, as they make this decision to go with a do not resuscitate order, they're thinking maybe they're going to neglect me. Maybe they're not going to come into my room as often as a nurse and treat me. Not so. You're a patient in the hospital to be cared for. All they're saying is you don't want the CPR. You don't want those kind of life-sustaining measures. So that could involve treating symptoms, surgery, feeding, dialysis. And then the palliative measures, D.N.R and hospice, palliative meaning pain management. And is your hospice work on that goal of possibly you might pass away within 6 months to be on hospice to get a doctor's order?
They just have to have a life-limiting illness.
Pardon me?
They just have to have a life-limiting illness.
Okay.
It doesn't necessarily.
Life-limited, not a 6 month. I don't know why Florida puts us into that 6 month thing. I mean, nobody has a crystal ball to know whether, but life-limiting. I like that better. Nutrition and hydration. This is another scare when patients are filling out an advance directive of living will, and they get to that little box, they check hydration and nutrition. They're going, you're not going to starve me, are you? You're just going to not bring water in my room? You're going to just make me die of thirst? Well, again, we're talking about persistent vegetative state when the body is not feeling those sensations of hunger, and rarely do we actually remove nutrition and hydration unless this is a hospice patient, unless it's not going to do any good to help the patient anyhow. So this is rarely be carried out for a patient. So don't fear that when you're filling out a living will that they're just going to leave you hungry. Or they're not going to take care of mama that way. That's a very extreme situation. And then in hospice says that as the body is declining,